Kia ora koutou katoa, and welcome to our webinar, Preparing for and Recovering from Knee Replacement Surgery, What to Expect with Dr. Simon Young. So tonight we have Dr. Simon Young on with us as our guest presenter. He is going to be taking us through what to expect before, during and after knee replacement surgery. So my name is Joanna and I am the health content creator at Arthritis New Zealand, Ngāta Ponapona Aotearoa. And I look after all of our webinars here. But before we get too much further, I'm just going to read a short karakia to open up our kōrero for tonight. So, tū taua mai I runga, tū taua mai I raro, tū taua mai I roto, tū taua mai I waho, kia tau ai, te Māori tū, te Māori ora, ki te katoa, homi e hui e, tai ki e. And the short translation of that one is come forth from above, below, within, and from the environment. Vitality and well-being for all, strengthened in unity. So now to properly introduce you to our guest speaker for tonight, Mr. Simon Young. He is a specialist orthopaedic knee surgeon based in Auckland, and he is the Director of Orthopaedic Research at North Shore Hospital, an associate professor at the University of Auckland, a board member of the New Zealand Joint Registry, and the current president of the New Zealand Knee Society. So after completing his orthopaedic training in New Zealand, Simon pursued further specialisation in the United States, undertaking a sports medicine fellowship at Stanford University and an arthroplasty fellowship at the Mayo Clinic. His research on knee replacement is internationally recognised, with over 150 peer-reviewed publications and multiple prestigious awards. Simon's research has contributed to major advancements in knee surgery, and some of his research interests include periprosthetic joint infection, knee replacement alignment, and patient outcomes. He also recently led the world's largest randomized trial on robotic-assisted knee replacement surgery conducted right here in Auckland, which is really exciting. So Dr. Young has also previously presented our webinar, which you may have seen, exploring hip replacement surgery, which you can find on our YouTube channel. So tonight, Simon is going to focus on how we can best prepare for and recover from knee replacement surgery. So if you are already on the waiting list for surgery, or maybe you've got a loved one waiting for knee replacement surgery, we do hope that this presentation will be helpful for you and your family or your support people. And just to note, this webinar is being recorded, and so that will be available on our YouTube channel in the coming weeks. And we will leave time at the end of the presentation for some questions, so please pop any of your questions into the Q&A box down the bottom there, and we will do our very best to answer some of them at the end. As always, we do apologise if we don't get the chance to get through all of them, but we'll do our very best. And so now I'm just going to hand over to Simon. Thank you.
Good evening, everyone. Thanks for joining the webinar. So I'm going to talk on knee replacement and a little bit just about arthritis and what it is. And obviously my specialty is orthopedic surgery. So the main operation we do for arthritis is knee replacement, and I'll be focusing on that. I'll talk over a little bit about anatomy in the knee, and the simplest thing to focus on when we're talking about arthritis is the articular cartilage, because articular cartilage is what wears out in all forms of arthritis, and it's this very special substance that coats the end of your bones, so that when two bones touch each other at a joint, rather than being bone rubbing against bone, it's smooth articular cartilage on smooth articular cartilage. So all joints in the body share this surface coating of cartilage, and it's a layer that's around sort of 4 or 5 millimeters thick. It's a little bit confusing in the knee because there's another kind of cartilage that sits between the two bones as well. The meniscus cartilage is a different kind of cartilage. It's a fibrocartilage that's like an extra cushion that sits between the femur bone and the tibia bone. So the job of the meniscus cartilage is simply to protect the articular cartilage, because that's the important stuff, the coating on the end of the bone. Now that articular cartilage, what you're born with is what you've got for life. Despite years and years of research, we haven't really come up with a way to make that cartilage grow back. So when you get damage to the articular cartilage, that is what arthritis is. All forms of arthritis share in common that that surface cartilage is damaged. Many of you will hear of people having a meniscus cartilage tear or having a procedure where they've had a piece of cartilage taken out of their knee. And generally that is the meniscus cartilage. So that's the cushion cartilage that sits between the two bones. And when people have small keyhole procedures to trim cartilage, that's what generally the type of cartilage they're talking about. But that meniscus cartilage is simply as a cushion to protect the surface cartilage, which is the important part. So to go over this a little bit more detail, so in the normal knee, you have your femur bone at the top there, your tibia bone or shin bone at the bottom, and then that surface cartilage or articular cartilage covering both the tibia, the femur, and also under your kneecap. And then you have the meniscus cartilage sitting in between those. In somebody who has arthritis or bad arthritis, that surface cartilage has been worn away. And as part of that, you often get extra outgrowth of bone called bone spurs or osteophytes. And it seems to be, it's almost as if your body can't grow new surface cartilage, but it can grow new bone. So sometimes when you get arthritis, you start to get extra bone growths around the knee. And also it might be that one side of the knee is wearing out more than others. So it starts bending or bowing or sometimes going in a bow direction or sometimes going in a knock knee direction. So you get deformity as well that goes with the arthritis. The meniscus cartilage might have been taken out or just wears away with wear and tear, and you get this narrow joint space, or people often use the word bone-on-bone arthritis. And all that means is just that the surface cartilage is being worn out. Osteoarthritis is the most common cause of arthritis, and that's probably about 90% of the people who I'm doing knee replacement on would have osteoarthritis. And it seems to be a wear and tear type arthritis, it's often termed. Other kinds of arthritis, such as rheumatoid arthritis or inflammatory arthritis, share in common that the articular cartilage has been worn out, but often the mechanism is different. And usually it's something to do with the body's immune system attacking the joint and causing it to be inflamed. And most of the time now, that is actually quite well controlled by rheumatological medications. The rheumatologists have got much better at treating things like rheumatoid arthritis or psoriatic arthritis or other forms of inflammatory arthritis. So it's much less common now for us to need to do knee replacements on people with rheumatoid arthritis because the drug treatments for them are now so good. In fact, most of the people who have rheumatoid arthritis that I see who need knee replacements have rheumatoid arthritis that's quite well controlled on medication and have developed more of a wear and tear type arthritis like osteoarthritis, which is why we're doing the knee replacement. So the two can sort of coexist. But in the past, rheumatoid arthritis was a much more common reason to do knee replacement. Now the medications for it are much better and it's less common for us. And most of our work doing knee replacement is osteoarthritis or wear and tear. So if you have osteoarthritis and there's quite a spectrum, right? From going a perfectly normal joint surface on the left there to a completely worn out one needing a knee replacement. There's a long spectrum in between. And a knee replacement tends to be what you're doing at the end of that spectrum when the knee is very worn. So while there's lots and lots of different treatments for osteoarthritis, I tend to think of them in three sort of buckets. So there's the non-surgical and non-operative, injections, or the surgery. And the non-operative encompasses many different things, but the two that have the most evidence are exercise and anti-inflammatories. And the exercise that's most effective seems to be an exercycle or bike. And the bike does two things. Firstly, if the joint surface is worn out, movement seems to be really good for it. So getting your knee going back and forward as many thousand times a day as you can seems to be good for the health of the knee joint. And the bike's just the most efficient way to do that because if you go for a 20-minute walk, your knee might bend and straighten 1,000 times. But if you spend 20 minutes on an exercycle, it'll be 3,000 or 4,000 times. So you're just getting more revolutions for your time. The second thing the bike does is build strength around the knee, and it's a very effective way of doing that. And it's also quite a good exercise because even if your knee's really sore, you can often get on the bike with no resistance at all on it and still manage to get some movement in. So it's a good way if you've had a flare of arthritis or you've injured your knee, it's a good sort of first exercise that you can do and then build up from there, adding a bit more time on the bike and then adding a bit more resistance as well. doesn't have to be an exercycle. A cross-trainer machine, a rowing machine. Walking also works, but as I said, you get less revolutions for your time with walking. But any gentle exercise seems to be good for your knees and good for arthritis. The second thing that has a lot of evidence for it is anti-inflammatories. Now, not everyone can take anti-inflammatories, but things like Voltaren or ibuprofen or Celebrex are common ones that might be prescribed by a doctor. And the way to think about those is rather than thinking, I've got this condition, how do I cure it? It's more about how do I manage it? And so trying to be smart with your anti-inflammatories and perhaps take them before you're doing something that you know will make your knees stir up. So if you know that going on long walks makes your knees sore, then rather than going on the walk and then taking the anti-inflammatory at the end of the walk, take it before you're going to do it. And that's a way of sort of managing the condition of arthritis rather than letting it manage you. Within this non-operative bucket, there's many other treatments that people will recommend. Things like weight loss, acupuncture, uh, heat packs, cold packs, uh, gels, rubs, many other things that people will be very happy to sell you as treatments for arthritis. And individually, many patients find some of those treatments quite helpful. But in terms of evidence, like good scientific evidence to say that this will help the majority of the people, exercise and anti-inflammatory have the most evidence behind it. For most of those other treatments, it's largely trial and error to see if some of those will work for you. One thing I would say is that try not to spend too much money on it, because the most effective thing that's got the best evidence for it is an exercycle, and that's generally free. It's just you have to find the time to get on it. The trouble with exercycle is it's relatively boring to do. So if you can set it up like this gentleman has with a phone or a YouTube video, so you're watching 20-minute spin class or 20-minute bike class, it can make it more likely that you're going to do it. The second treatment that's often recommended is some form of injection, and there's many different things that you can inject. The simplest is a cortisone or a steroid, which tends to help for a period. It's not going to cure the arthritis. It's not going to make the cartilage grow back on the surface of your joint, but it may give you some temporary relief. And the way I sort of say it's like taking a handful of Nurofen and putting it inside your knee that might last for a few months. There are other things that people inject, something called PRP, where they take a sample of your blood and spin it down to concentrate growth factors, or gels or hyaluronic acid. Those injections generally cost and seem to have some benefit to them, but the evidence for it is fairly mixed. The steroid tends to be covered by insurance or ACC, but PRP and gels tend to not be and tend to have some cost attached with it. There does seem to be a negative effect on cartilage if you're having a lot of injections. So a single steroid injection doesn't seem to have a negative effect, but multiple steroid injections over many times may actually accelerate the arthritis. So that disadvantage doesn't seem to be true for the PRP or the gels, which is why some people may recommend them more. There's also something called stem cells, which people inject that has like the science behind that is good, but it tends not to be a sort of mainstream practice. They're very expensive, and the data on it shows in showing that it improves outcome doesn't seem to be there, despite a lot of research and a lot of trying. Those more expensive injections don't really seem to have good data behind them, and they tend not to be something that's offered in the mainstream. And then finally, surgery. And bear in mind, I'm a surgeon, so this is the focus of the talk. And by far and away, the most common operation we're doing for arthritis is a knee replacement. Smaller keyhole surgeries or cleanup procedures don't seem to work that well. And knee replacement is now largely taken over as the sort of one operation we're aiming to do on somebody who has severe arthritis. You may also hear the word osteotomy, which is a procedure where we realign the bone. A little bit like if the tires on your car are wearing out and the two tires on one side are wearing out on the car, you might try and rebalance the car so that more of the weight is going through the good side. And that's what we do with an osteotomy. It tends to be done in younger patients. As knee replacement over the last few decades has gotten better, we're doing knee replacement in more and more often and in younger and younger patients. So osteotomy is less commonly done than it used to be in the past, but still in people in their 30s and 40s who have significant arthritis that's just affecting one side of the joint, that may be something that you hear offered to people. Just to give an illustration of sort of how popular knee replacement has become in New Zealand. This is data that we looked at taking information from a New Zealand joint registry, looking at what are the chances of somebody ending up with some form of knee replacement in their lifetime. So the numbers there for total knee replacement at the top and unicompartmental or partial knee replacement at the bottom. So overall now in New Zealand, the chance of a New Zealander ending up with a knee replacement in one or both knees during the course of their lifetime is about 1 in 6. So it's pretty common. So if you're suffering from arthritis out there, you're certainly not alone. So what is a knee replacement? Well, I spoke to you about how arthritis is the surface of those bones there wearing out. And so a knee replacement is simply a resurfacing. And resurfacing would be a much better word to describe it rather than replacement. It's not changing the ligaments, it's not changing your muscles, it's simply taking that worn out cartilage surface and replacing it with a surface made of metal on the femur bone there, and then polyethylene on the tibia. So looking at the surface cut, we simply skim cut off the surface of the bone all around the femur. We skim cut the surface of the bone off the tibia bone there, and then replace it with a metal plate on the tibia, a metal surface on the femur, and then a piece of polyethylene or plastic that sits in between. We also often resurface the patella bone as well, which is not shown on that picture. So an analogy I often use for patients, if you think of the surface of your joint like a brand new car tire that you're born with, and the articular cartilage like the tread on that tire. And arthritis is when the tire gets completely bald and needs changing. And really the main determinant of that is time. So you're born with that brand new articular cartilage or a brand new tire, and it tends to wear out during the course of your lifetime. But not everyone's tire seems to wear out. Some people seem to have good genetics and they don't go on to get arthritis. But a major factor is also injuries. So if you've been hitting the curb with your tire through the course of your lifetime, especially if you've had surgeries or operations on your knee through the lifetime, then there's a much greater chance that the surface of the joint will wear out and you'll go on to get more significant arthritis. But it's not an inevitable consequence of getting older. It does seem to be that your genes play a significant part. And in studies, most people's, or the percentage of arthritis that is attributable to your genes is around sort of probably 60 or 70%, with the rest made up of injuries and environmental things that have happened during the course of your lifetime. So the key decision though, or the hard decision is often, well, when do I get a new knee replacement? When does the time come to change my tires? And when you look at this sort of picture or between having a very normal knee replacement, no symptoms at all, and having a completely worn out tire and needing a new one, there's quite a lot of symptoms that are annoying, but maybe not severe enough yet to need a knee replacement. And that is what is challenging to decide, when is the time to pull the trigger? When should we do this knee replacement? And so when I'm seeing people in clinic, the sort of things I'm thinking about is how much pain is someone in? Because pain's the main reason we're doing knee replacement for. It's a disabling symptom, but it's also quite hard to quantify. It's quite hard to say how much pain is somebody in. Two things that we often ask is, are you taking painkillers regularly? That's not a perfect question because a lot of people don't like taking pain relief and prefer just to soldier on. But if somebody's needing to take painkillers regularly, that is something that we can tend to help with a knee replacement and often get people off the need for regular painkillers. The other question is the pain disturbing your sleeping? Because that's quite an impact on your life. If you're waking up through the night because your knee's sore, that's pretty disruptive to the day. You're not sleeping well. So it's quite an impact to not be able to sleep well because of arthritis pain. So while pain is sort of hard to quantify, if somebody's taking painkillers regularly and it's disturbing their sleep, then those are sort of two markers where we think this person might be ready to consider a knee replacement. The next and maybe the most important question is function. What is your arthritis stopping you from doing? And importantly, if we gave you a knee replacement, would you be able to get back to that? Because somebody who says, well, I can't run marathons anymore because I've got some early arthritis, a knee replacement won't let you go back to running a marathon. So it's maybe not going to meet the goals of that patient. But if you're not able to go for a 10-minute walk because your knee's sore, then that's certainly something that you can get back to with a knee replacement. And so you're thinking that this we might be able to help this person get back to the things they want to do with surgery. For individual people, that's quite, what they're not able to do and what they can do is variable on the hobbies and goals they have. Knee replacements are now done in fairly active people. So while generally you won't be running on a knee replacement, you might be playing tennis. People ski on them, certainly walking long distance, including hiking, cycling, gym-based activities. That those are all sort of things that fairly optimistically we can get back to with an artificial knee, with a knee replacement. The next question is, are your symptoms worsening? Particularly, if you're on a wait list for public hospitals, it varies around the country, but often if you're referred by your family doctor into the public hospital, you might be waiting sort of 6 to 9 months to be seen in clinic. And then if you're seen there and agreed to have a knee replacement, it might be another 9 to 12 months before you actually have the surgery. This changes, depending on the amount of resource that's being put in by the government into public wait lists. Certainly, I think before COVID, it was less time than that. But if you're at the point where you're thinking of a knee replacement and seeing your GP to be referred in, it's likely to be at least a year and more likely, I think, probably 18 months before you're actually being wheeled into the operating room. So if your symptoms are sort of getting worse, you need to think about that lead time if you're going in through the public system to have your knee replacement. So those things, or those three things, are the main factors that I'm looking at in deciding whether or not somebody is ready. But overall, what you're trying to juggle here is the risks of the surgery versus the benefit. And the risks tend to vary also from person to person. Everybody who has a knee replacement, there's a small risk of infection, there's a small risk of blood clots. Those risks are generally low, but they're there. Some other people may have greater risks. So if you have a cardiac condition, if you've had a history of blood clots, if you've had a history of problems with anesthetics, those risks might be greater. And therefore, you're wondering, how much difference will it take to how much difference will the knee replacement make to my life? How much benefit am I going to get from it? Because the worse your symptoms are, the greater the room there is for a knee replacement to make your life better, and therefore the more justifiable it is to take those risks. So in every patient we see, we're juggling these risks versus benefits. And they also depend on the stage of life you're at. So if you're a 55-year-old builder who can't work because of their knee arthritis and they're otherwise fit and well, then there's generally a great benefit to that knee replacement. Might be able to get them back to work and living out the later stages of their working life productively, and the risks are fairly low. So that equation, even though that patient's young, might be more in favor of doing a knee replacement. Where if somebody is 85 and they have a number of health issues and the risks are higher, and you're also wondering how much difference will a knee replacement make to an older person's life. If it's the only joint in their body that's limiting them, then there might be enough benefit. But if they've got some knee arthritis, they've got some hip arthritis, some ankle arthritis, replacing just one joint may not be enough of a benefit to that person's life to justify taking those risks. So that's the decision that your doctor, your surgeon will be thinking about when deciding whether or not to recommend a knee replacement surgery. So if you have a knee replacement, you may be talked about whether to have a partial knee replacement or a total. And I'll just touch on this briefly because I think it's actually a little bit less important than it may seem, because they're both knee replacements. The difference between them in outcome is not huge. And if you're deciding whether or not to undergo a knee replacement, the first is that risk-benefit decision, and then you might choose about whether or not to have a partial or a total. So in this X-ray, you can sort of see here that the left and the right knee both have very narrow joint spaces. And this is what we mean by bone on bone. When you look at an X-ray of somebody with arthritis, you can see a gap between the femur bone and the tibia bone. That gap's not really a gap at all. That's where that surface cartilage sits. So the X-ray beam goes straight through that cartilage. So when someone's standing up when they're taking this X-ray, if they've got a good gap there, they've got a good cartilage or good surface joint. So you can see this patient has a nice gap on the outside, but on the inside here, there's no gap at all. The bone is rubbing on the bone in both the left and the right knee. So for this patient, if you think of the car, again, using that car analogy, the wheel on the inside of their knee is worn out, but the wheel on the outside actually has quite good cartilage. So this person might choose to have a replacement that only replaces just the inside part of the knee, which is what a unicompartmental knee is here. You can see here we've just replaced the inside part and the patient's kept their own compartment on the outside. And this one on the other side, you can see the full knee has been replaced. Now, the advantage of the partial knee replacement is that it's a slightly smaller operation and generally a little bit quicker recovery, and the knee often tends to bend a little bit better. The disadvantage is that wheel that we've left unreplaced one day might need to go on and get replaced. So the chance of it needing a second operation to replace the full knee is much higher if you're having a partial knee replacement rather than a full knee replacement. Now we have a registry in New Zealand that records everybody who undergoes any form of knee replacement. And that's been running since about 1999. So it's one of the best sort of registries, I think, in the world in terms of data analysis, and really good for someone like me who's interested in research and analyzing about what the outcomes are for knee replacement and when we do them. So this is a table from a study we did looking at the joint registry. And it looks at that risk between unicompartmental, which is the UKA on the left, and total knee replacement on the right there. And it looks at what is the lifetime revision risk. So this is data from New Zealand, so over the last 20 years. So if you are a 50-year-old or 50, say 51-year-old woman having a knee replacement and you're suitable for a partial knee replacement, the chance of that needing a revision in your lifetime, that means a second operation, is around 38%. Whereas if you have a full knee replacement, the chance of it needing a revision is 16%. Another way of saying the same thing is that if you have a full knee replacement when you're 51, then there'll be an 84% chance it should last your entire life. Whereas if you have a partial knee replacement, it'll be a 62% chance it'll last your whole entire life. So those are numbers from New Zealand. One thing I think to take from that is that people often sort of say, oh, the knee replacement lasts 10 years or it lasts 15 years. In fact, everybody who we put a knee replacement in, be it a partial or a total, we are hoping that that will be the one operation that that patient has. The idea is for it to last the rest of your life, to last as long as you do. The older you are, when you have a knee replacement, of course, the greater chance that it will last your whole life. Not just because you've got less time to live, but also what you do in your knee as a 70-year-old or an 80-year-old tends to be less aggressive, less miles on the clock than somebody who's in their 40s or 50s. So you see those chances of it needing revised go up a lot when you're younger. For somebody who is 76, if they have a partial knee replacement and they're male, the chance of needing it revised is 9%, so a 91% chance it'll last their whole life. If they have a full knee replacement, a total knee replacement, then there's only a 5% chance that it'll need revised during their lifetime, 95% chance that it won't. Most of the time now is actually in those, especially in people who are over the age of 65, most of the time now, it's not so much the knee wears out, it's usually some other unusual complication like infection or a fracture. The modern prostheses are pretty good, and wear of the joint surfaces, the polyethylene or the bone adhesion where we cement them or place the implants on the bone, that's actually less common now than it was in the past with modern implants. It can still happen, but most of the time, especially in older patients, we're revising for things like infection or fracture. So if you've made the decision to have a knee replacement, what can you do to get ready for the day in the operating room? Well, the first thing is exercise. And just as that is the same treatment for if you're not planning on having surgery, if you know the first non-operative treatment there for arthritis, getting on an exercise cycle, getting your knee strong. Because the stronger your knee is leading into the surgery, the easier you'll find the rehab afterwards. And I think that certainly is a key message leading up to the surgery. You'll find it easier if you can do that cycling. 20 or 30 minutes a day, 4 or 5 days a week will make a big difference in getting you ready for the surgery. The second is weight loss. It's not always easy for people, but certainly if you can get your weight down prior to surgery, then that decreases your risk of having a wound complication, it decreases your risk of having an infection, and that is a key sort of factor, I guess, in terms of trying to optimize people leading into the surgery. Smoking's a big no-no. It increases your risk of infection by a factor of 4 or 5 times. So in many parts of the world, people will not do knee replacement on patients who smoke. It's not always easy to quit smoking, and vaping is better than smoking, but not vaping is better than nothing. Sorry, nothing is better than vaping, I should say. But if you're thinking of having a knee replacement, then giving up smoking is something you should absolutely do. Because if you were to go on an infection, then to get an infection after knee replacement, it is a major problem. Not because it's common, it's less than 1%. But if you have an artificial joint and you were to get an infection, then it's generally very hard to clear. It often requires multiple trips back to the operating room and antibiotics through a drip for up to 6 weeks. trying to clear those infections. So it's a very challenging problem around an artificial knee joint. So if you can stop smoking, then that'll lower your risk. Other things we talk about are optimization, and this is dependent a bit on what your medical history is. If you have diabetes, you want to make sure you've got really good diabetes control leading into it. If you've got high blood pressure, you want to make sure your blood pressure is well treated. So if you don't have a lot of medical conditions, then that's less of an issue. But if you have other health issues, it's important to make sure that those are as good as they can be made before you undergo a big operation like a knee replacement. And your family doctor, for cardiologists, if you have a cardiologist, will often be asked about this. Is there anything more we can do? Do we have this condition under control before we put you through an elective knee replacement? One thing you may hear about in doing knee replacement is technology, and this has evolved a lot in the last 10 years. We got the first robot in New Zealand in around 2016 at North Shore Hospital to assist with knee replacement. The other things you may hear about is navigation systems. And essentially what these do is just help us make the cuts more accurate. So this is a picture of a femur bone being cut before we're going to resurface it. We're using a robot here, which has got guide and navigation to help us position the components. I think these are small increments. So they're a good research tool. This is a study that we've just completed here. This is one that Joanne mentioned. This is the largest randomized study looking at robotic knee replacement in the world. We've just finished publishing this study. I think there's some small gains to robotic knee replacement in that it helps you be more accurate. But if you're seeing someone who's not doing robotics, then I don't think you need to think that you're missing out a great deal. The robotics don't change the implant that we're putting in. It's still the same prosthesis. It's still the same joint replacement. The robotics or navigation that people might use just help us be a little bit more accurate in how we're placing them. So it's a small advantage, I think, to surgery, but I don't think you need to be sort of too focused on exactly how this is going in. The prosthesis that most modern knee replacement prostheses are fairly similar between the different companies now, and the outcomes on our joint registry are fairly good or very good for the majority of the common prostheses that are used in New Zealand. And then finally, recovery. So if you're in hospital, just what to expect when you're coming in. So generally now we're much more aggressive at getting people up and mobilizing after knee replacement. In the past, people used to have quite prolonged hospital stays, but the trend worldwide has been to try and reduce this, not because we're mean and we want to kick people out of hospital, but it seems that the quicker you get the body up and going, the quicker you get it up and moving, then the faster your recovery and the less risk of complications like blood clots or chest infections. So in much of the United States now, this is often done as a day stay procedure, so you don't even stay in hospital overnight. And also, we're much better at the pain control aspects of this. So I won't pretend that there's no pain associated with it, but I think we're much better at managing it than we were even sort of 10 years ago. In New Zealand, most people will still stay in hospital for at least one night, but we're generally trying to get people up and out either the next day or the day after. As I say, to minimize the muscle wasting, to minimize the risk of blood clots, and it seems that the outcomes are better if we can get people up and get them moving quicker. You generally will have crutches, but the crutches are for balance rather than for not being able to walk. So we'll try to have you up usually on the day of surgery, so that evening, even if it's just standing up to go to the bathroom. And the crutches are just there to help you with balance rather than saying you're not allowed to put weight through or anything like that. The focus on the rehab early on after knee replacement is movement. And you have this sort of window to try and get that motion back. And by motion, I mean getting the knee fully straight and getting it bending well. And that movement, we want to get your bending to at least sort of 100 past 100 degrees. How much past that is a bit variable, and the biggest predictor of how people move after the surgery, how well they bend after the surgery, is how well they were bending before. So a lot of people with arthritis tend to have quite stiff knees. But if you can't bend your knee past 90 degrees, then it's quite hard to get in and out of a car, to sit in a movie theater, to get up out of a chair. So we do like you to try and get to 90 degrees, especially in that first sort of few months. There's quite a bit of variation in how people go in the first few weeks after surgery. So if somebody's struggling to get movement on day 2 or day 3 after surgery, that's generally not too much of a worry, as long as they get there over the next few weeks. And there is a percentage of people who are not getting their movement back, say by week 6 or week 8. And we might even consider doing something called a manipulation, where we put people to sleep again and simply push on the knee. So no more surgery, no cuts or anything. We just literally push on the knee to try and help break down the scar tissue, because getting that movement back in the first few months is important, because if you don't get that movement back early on, the scar tissue tends to set in, and then it's harder to get that movement later. Then finally, the other focus is strength. When you've had arthritis for a long time, your muscles tend to waste away, and replacing the knee and hopefully fixing the arthritis doesn't magically make those muscles come back. And it takes months really for that strength and muscle control to come back. And you won't feel confident in your knee until you get that strength back. So we often say that you recover to 60 or 70% of hopefully normal by 3 months, but getting that last 20 or 30% of recovery takes 12 and even out to 18 months to get all your strength back and get fully confident in your knee. And so there's a relatively quick early recovery after knee replacement, but often a very long tail before you feel like you're fully adapted into the new knee and got your knee strong again. So overall, I'll just go back now with some key points to conclude. For knee replacement, it's good to think of it as a resurfacing. That arthritis is that surface cartilage wearing out, and a knee replacement is a new joint surface. We're much better at the recovery now, at getting people back on their feet earlier after surgery with better anesthetic techniques and sort of more enhanced mobilization. If you ask 100 people with a knee replacement, are you satisfied? It's now in New Zealand around over 90% of people will say that yes, they are satisfied. It's not 100%, but this is as good as anything really that we do in medicine. Some of the reasons that people are not satisfied, some people may have persistent pain. Sometimes people may have other factors, other joint pain that's affecting their mobility, and their knee replacement hasn't given them the result they want. But in general, the outcomes of knee replacement are excellent. And while the younger you are, you have a knee replacement, the greater the chance that you might need it changed in your lifetime. Largely now, if we're doing a knee replacement, we're hoping or aiming for it to last the rest of your life. That's pretty well true for certainly people into their 70s and 80s and also into their 60s. If you're younger than age 50, we're pretty cautious with knee replacement. We do them occasionally in people in their 40s or younger. But more often it's an operation that we're doing in people who are a bit older, because we want it to be the one operation that we're doing to last that patient's lifetime. Thank you.
Oh, thank you, Simon. That was fantastic. It was really interesting and quite fascinating, actually. I certainly learned something tonight. So we've had lots of really great questions come through from our audience.
Good.
Okay, so one of our questions is, this person had a knee replacement in July last year and had a MUA in November. They're wondering if there are any specific exercises to get more bend in their leg, because they're having a lot of trouble bending still.
Yeah, I mean that's sort of what I mentioned there. It is a percentage of people after knee replacement seem to struggle to get the bend back. It's often people who've had previous surgeries before or more complicated type forms of arthritis. But sometimes it just happens to out of the blue that people have a scarring reaction that makes their knee very, very tight. Really, you want, rather than trying to have it bent all the time during the day, you want to have periods of the day where you're sitting down, focusing on bending the knee until it's uncomfortable, like 4 or 5 or 6 out of 10 discomfort, not 10 out of 10, holding the stretch for 10 or 15 seconds and then relaxing. A physio is a good person to talk through about some of those exercises, but yeah, 4 or 5 times a day, you want to be doing a stretch exercise where you're holding the bend for 10, 15 seconds, relaxing, and then doing sort of 3 sets of 10 seconds, at least sort of 4 or 5 times a day.
Awesome. Another question is it possible to get 2 full knee replacement operations at the same time?
Yes, it is, and juggling that sort of risk-benefit equation there. If you have both knee replacements at the same time, the risk is a little bit higher because it's more of a stress on your heart, it's more a stress on your lungs. So generally, we're doing that in patients who are younger and have a bit more reserve in their cardiac and lung function, so they're more likely to be able to cope with that bigger operation. The person it makes the most sense for is somebody who is working, because the big advantage of having both done at the same time is that it minimizes your time off work. Um, you only have to go through the recovery once. It's a tougher recovery because you're generally in hospital a little bit longer. You're on crutches a little bit longer because you're having this bigger operation. But because you're only having it done once, you can sort of it's a much better if you're going to have that impact on your working life. Um, the
Mm,
cut-offs are generally decided by the anaesthetist, saying that yes, this person's fit to have both done at the same time, but it is um, fairly subjective. It's not a hard and fast rule. Personally, I would be pretty cautious doing it on anyone over the age of 70. Um, and even then, the people under 70 would have to be fairly fit and well, and able to cope with both knees done at the same time.
yeah, it sounds a pretty major ordeal for both at the same time for
Yeah.
someone a bit older. Um, okay, so the next one is knee replacement suitable for the damage caused by pseudo gout or calcium pyrophosphate disease, or will the crystals come back into the joint and cause more pain despite the new joint?
No, they don't seem to. So the two forms of arthritis that are to do with crystals are gout and pseudo gout, and both seem to be cured by knee replacement. Pseudo gout tends to go along with, like, usually there's also some osteoarthritis as well. So you tend to see them both together. I'm not sure that I've ever done a knee replacement on somebody who just had pseudo gout. Almost certainly they've got some osteoarthritis going on as well. Um, but you're generally wanting to do that in somebody who's in the age range where a knee replacement's a good idea. So I sort of see on that question there, you're saying you're in your 40s. You'd be pretty hesitant doing a knee replacement on somebody in their 40s. It's not a never, but you'll be trying to manage that pseudo gout with other things like injections or anti-inflammatories, rather than a knee replacement in general. Of course, you'd need to see you in person and discuss all the pros and cons of those options.
Mm, yeah, absolutely. Will I be able to go up and down stairs comfortably after knee surgery? And I guess that comes back to, like you talked about before, were they able to do that before, or
Yeah.
did
I
they
mean,
not have that ability?
that would certainly be a goal, right? Like that would
Mm,
be, you would be disappointed if you couldn't go up and down stairs after a knee replacement. It does depend a little bit on other factors. Somebody who has a lot of muscle deconditioning or arthritis in other joints might find that more challenging, or someone who's more elderly. But certainly, no, going up and down stairs is what we would be aiming for, to be able to do after a knee replacement fairly comfortably. Going downstairs seems to be tougher on the knee joint. So often people with early arthritis will say the first thing they noticed was that going downstairs or going down hills was difficult. It can be the same after knee replacement. Your knee might be fine with just walking on the flat, but that going down hills it might cause a bit more symptoms.
mm, okay. And someone has asked why there was a difference between males and females in terms of that lifetime revision risk.
Yeah, I'm not sure actually.
Hmm.
There's lots of factors in that. It's a so that table there is fairly simple, but there's a lot of sort of data analysis that we've done behind that. Males seem to have a slightly higher risk of infection. Females seem to have a slightly higher risk of being revised for unexplained pain. But those seem to be the differences that are in a unicompartmental or partial knee replacement seem to do slightly better in males, and a total knee replacement seems to do slightly better in females. But the differences are relatively small. I don't think you have to sort of worry too much about that. I think both
Mm,
options are viable in males and females. It's something you can see in the data, but it's not the difference is not of a magnitude that it affects the treatment decisions a great deal.
yeah. And there's another one. Actually, no, we've answered that one. It was another one about the someone with CPPD asking whether it was they found that theirs was sort of triggered a bit by exercise. Was there anything preventative they could do? And then asking about was it common to do those knee replacements, which you've answered previously about the other CPPD question.
Yeah, I mean the CPTD is yes, there are treatments for that. I mean it's something that a rheumatologist or your GP would talk to you. There are medications that you can take regularly to try and prevent the
Mm,
flare-ups, and then injections can sort of are another option as well.
mm. Um, I've got a question. How common are, I think they're meaning, how common are nerve blockers to manage pain post-surgery?
They are common. I mean, a common nerve blocker is a medication called gabapentin, and most people having a knee replacement now would be given that for a short period afterwards. Um, One of the potential complications of knee replacement or any surgery is getting some persistent nerve pain, and that's where those nerve blockers tend to come in. Um, and it falls into sort of the category of unexplained pain as well. And those nerve blockers tend to come at the pain from a slightly different angle than the common things that we take, like paracetamol and anti-inflammatories. So sometimes pain that's coming from nerves that are not well controlled by anti-inflammatories might be well controlled by those nerve agents. But you kind of hope if everything's gone well with the knee replacement, you'll be hoping that you're on those for a short period and then getting off the painkillers fairly soon after the knee replacement. You know, that's why we're trying to do the surgery is to get you off pain relief.
Mm,
And yeah, and we would hope that everything going well that was a short-term course of nerve agents after the knee replacement.
mm. Now I'm going to combine two questions together here. Someone asked about, so they live on their own and they were wondering about whether they need someone to help them post-op. And then also there's another question that sort of talks about what advice would you give to families to support someone afterwards? So kind of combine those together, that I'm going to presume if you are living alone, it might be a good idea to have somebody around to help out. So what would be
Absolutely,
your
yeah. I mean,
recommendations?
it's quite dependent on sort of how well you're functioning. You know, so an 80-year-old living alone is quite different to a 50-year-old living alone. But
Mm,
we do knee replacements all the time on people who are going home by themselves. It is much nicer if you've got somebody who can help with meals, or if you've planned ahead so that you've got meals available. Other things like, do you have lots of stairs at home? You know, is your bathroom on the same floor as your bedroom and your kitchen? It might be useful if you're living by yourself in a multi-level home to spend a few days somewhere that's everything's on one level. That's quite individual. I think what you can expect if you have a knee replacement, that you'll be using some form of crutches for the first few weeks after surgery. So it's anywhere from sort of 2 to 4 weeks afterwards. So if you've got a lot of stairs in your home, that might be more challenging. The help is great if you can manage it, but lots of people do go home by themselves. You know, so it is something that you could discuss with the hospital, with your surgeon, with the team around it. You know, it is something that we consider in a very used to answering questions on for individual people.
hmm, great. Okay. The next one is, I have a sedentary job. What's the minimum amount of time I would need to take off, and how soon would I be able to drive? Um,
So
yeah.
driving generally, we say that you've got to be off crutches. There's not hard and fast rules about this. You sort of think there might be something from insurance companies, and it's actually largely when you're safe getting around, then you're able to drive. If it's an automatic car and it's your left leg, you can get back quicker than if it's your right leg. Um, because most people are on crutches for sort of 2 to 4 weeks, then I would usually say that you can drive after 2 to 4 weeks. And if it's your left leg and it's an automatic car, then you may be able to get back a little bit quicker than your right leg. The
Mm,
other thing to think about is pain relief. You know, some of the very stronger pain reliefs are advised not to drive, but we would hope that you're off those during the day by that sort of 2 to 4 week stage if everything's going well. There is
mm,
quite a lot of variation in how people recover in that first 6 weeks. So if you were thinking about the time that you need to take off work, if you can get some flexibility in that, that's really helpful, because you'll have a really good idea of how you're tracking even by the sort of second or third day after surgery. You know, some people seem to be lucky and have very little pain, very little swelling, and get going very quickly, and other people sort of get a bit more bruising and struggle a little bit more in that early period. So if you can have some
mm.
flexibility in the time you're taking off work, then that's helpful.
Okay, that's really good to know. Um, this person has said they've had both hips replaced, and they're wondering about whether there is, or they've presumed that there's a higher risk now for getting a knee replacement because they've already had two hips replaced. Is that correct or not? Not quite.
Not quite. Yeah, I mean arthritis. A lot of arthritis is in your genes, but it's also quite joint specific. So not everyone who gets a hip replacement goes on to get a knee replacement by any stretch of the imagination. Um, I think if you've got your left hip replaced, then your chance of needing a right hip replacement is certainly a lot higher. But your knees are not quite independent, but they do tend to have different genetic factors that are associated with knee arthritis than hip arthritis. Yeah. I mean, there's certainly,
Mm,
I've got plenty of patients who've had both hips and both knees replaced, but that's actually not that common. Not that common.
mm. Someone has asked about whether there's a particular BMI that's acceptable for knee replacement, and why is increased weight a risk for knee replacement surgery?
Yeah, it's a great question. I mean, this is a great question and a topic of conversation amongst at our conferences. So parts of the world have what we call a hard stop. So they'll say that a body mass index, usually the number people will use is 40. So a body mass index greater than 40. They where the complications seem to increase, and the main complications seem to be infection or wound problems. And part of that is if you've got a higher body mass index and you've got more, we call it adipose tissue or fat around your knee, there's a greater chance of having a wound issue. But it's also actually some of the effects that having a high body mass index have on your general metabolism. So you're more likely to be diabetic, um, and therefore that issue seems to be that you're less likely to be able to fight off an infection. What's hard is that the after a knee replacement, your infection risk is hopefully sort of less than 1%. And a surgeon might say, well, you've got a high body mass index, so your risk is doubled. It's now 2%. And the patient might say, well, that's 98% chance I won't get infected. But the surgeon say, well, I don't want to do the surgery because your risk is twice as high. And it's a topic of controversy. In general, um, people who are over the eight have a body mass index over 40, we are trying to recommend first that they take actions to lower their weight if they can. Um, I personally don't have a hard stop for that, but certainly would advise someone with a very high body mass index to see if they can take measures to lose weight as well. Because it pushes that in that risk benefit equation for the surgery, it pushes the risk higher. Yeah, it pushes the risk higher. It's if you can get it down, then that's uh, uh, greater chance of getting a good outcome. I think over time, in the next 10 years, the GLP medications, the Ozempic and other ones are going to make quite a big difference to that because it's yeah, certainly in America now, that's something that joint replacement surgeons are recommending that people take before they have their surgery, and their outcomes seem to be better.
Mm. Okay, I think we've got time for maybe two more questions, and then we will wrap things up for tonight. One of the questions was, do knee replacements or the materials that are used break down over time and cause further damage? And then if it has to be redone, is there a lot more bone that has to be removed, or is it just a simple replacement of that part?
It's a great question, and that is historically been the problem with artificial joints is that the materials we use with them have worn out over time. And that's sort of where often people talk about a knee replacement lasting 10 years or 15 years. That's largely a problem that has been solved. Yeah. Still, the components can wear out, but the modern prostheses that we're using, it's a much less common reason for them to wear out. Of course, if you have a knee replacement when you're 30 years old, then there's a very high chance that won't last your whole life and will wear out with time. But for most people having a hip or knee replacement, the components wearing out or becoming loose is less of an issue than it was in the past. It certainly still happens, and it's still an area of ongoing research to try and make these components better and the fixation of them better to bone, so that's less of an issue. But it's in the last 20 years that's been a big advance, I think, in knee replacement. To ask your question, if you did need it revised, if you did need to have another one, um, it depends on what's happened. So if one component has come loose or had a problem, then you just replace that one. If they've all become or starting to have an issue, then you tend to replace the whole lot. And the outcomes of that second operation are often reasonably good. They're not as good as the first one, but a lot of things that go into what the outcome will be. Why has it failed? Is it an infection? Is it a fracture? Or has the components come loose? Or has there been a breakage of component? There's a lot of things that go into that revision surgery, we call it, that determine the outcome. But certainly that is a big part of my practice in public is revising failed knee replacements. And if that was to happen, then there's certainly options available.
Okay, that's great. We might just ask one more question if that's all right, Simon, and then we will wrap things up. This question, actually, we've got one that's come through the chat here, and a similar one came through an email before this webinar from someone who is really excited to listen in. This person, and I'm going to presume it might be the same person, this person said that they had lymphedema or lipedema in their legs, and they're wondering about whether that would affect them having knee replacement surgery, and how it might impact on it, if they need to do anything differently. Is it okay to have surgery alongside those kind of conditions?
Yeah. Lymphedema, for those who maybe don't know, is where the lymphatic drainage of the limb is compromised, and people tend to have a lot of swelling in the lower limb. It often goes with recurrent infections, not always, but often does. And it also means that if you do an operation and there's a lot of additional swelling from the surgery, the lymph fluid isn't as good as draining it. So lymphedema is something that we're really nervous about when doing a knee replacement. It's not to say that you would not be allowed to have one, but in that risk-benefit equation, lymphedema pushes that risk very, very high, especially if there's a history of infection. And oftentimes that risk is so high that it makes the benefit of the surgery unclear. And so oftentimes that is a reason that the surgeon may say, look, we don't think a knee replacement's a good option. But you would need to look at your leg, see how severe the lymphedema was, and go through that sort of assessment. So yeah, you need an individual assessment of the degree of lymphedema, but the surgeons will be pretty cautious with doing a knee replacement in somebody with severe lymphedema.
Okay, thank you for answering that and for answering all those other questions. I'm sorry we haven't got through them all. We've had a huge amount of questions come through, which is fantastic, but hopefully this has been really informative for everyone and helpful. I know I've certainly learnt a lot tonight, but we are now just a bit after 8 o'clock now. So I just want to thank Simon for your time tonight. And we really appreciate you sharing your knowledge with our community. And again, sorry we didn't get through all of those questions. We will have more webinars throughout the year, and this one will go up on our YouTube channel, so you can rewatch it again, share it with any whānau or friends that might be going through knee replacement surgery in the coming year, and I'm sure they will get a lot out of it as well. So thank you, Simon. I am going to just close us off tonight with another short karakia, unless you'd like to say anything else before we head off.
No, thank you for having me. Very enjoyable. Thanks for all the good questions.
Yes. Alrighty, so I'm just going to share a short karakia and then we will finish off for the evening. So tu taua mai I ronga, tu taua mai I raro, tu taua mai I roto, tu taua mai I waho, kia tau ai, te Māori tū, te Māori ora, kia te katoa, homi e hui e, tai ki e. So thank you everyone for coming tonight, and thank you again, Simon, for your time.
Have a good evening, everyone.